Hi, I'm Dr. Nitin Adasulu from Sir Gangaram Hospital, New Delhi. The topic of my presentation is lumbar canal stenosis, a clinico-radiological analysis. The lumbar canal stenosis is characterized by narrowing of the spinal canal, compression of the dural sac, entrapment of the nerve roots, and a neurological claudication. This constriction pressure adversely affects the nerve function. Theoretically, more stenosis should lead to the more pressure and more neurological symptoms. Although the spinal canal narrowing is thought to be the defining feature for clinical diagnosis of the lumbar canal stenosis, the degree of the spinal canal stenosis necessary to elicit the neurological symptoms is not clear. Despite significant spinal canal narrowing, patients may have minute or no clinical symptoms. So the radiological changes were more extensive than expected from the clinical picture, and the degree of narrowing did not correspond to the degree of the clinical affection. Since the dural sac cross-section area was not able to always accurately assess the clinical severity of the symptoms, other methods were proposed like qualitative grading or the morphological grading and the nerve root sedimentation sign. So the qualitative morphological grading for lumbar canal stenosis, it has been divided into A, B, C, D. So the A is again divided into the four types: A1, A2, A3, A4, and the B1 is the grainy appearance, and the grade C there is some epidural fat, and the grade D is there is no epidural fat. The nerve sedimentation sign, as proposed by Barth et al., a positive sedimentation sign is defined as the absence of nerve root sedimentation in at least one transverse MRI image at a level above or below, disregarding the location of the site, location of the scan within the level and its proximity to the maximum stenosis. So this is the negative sedimentation sign showing the normal MRI, and this is the positive sedimentation sign absent of nerve root sedimentation. So in our study, the aim was to find out the best radiological and the clinical criteria which can reliably predict the severity of the symptoms clinically in lumbar canal stenosis patients. So objective is to assess radiologically in each patient by these three radiological criteria and the clinical criteria, including the ODI and the self-reported walking time, and compare these clinical and the radiological criteria. So we assessed total 85 patients. They included patients with symptoms of neurological claudication, excluded the vascular and the neurological disorders. So the patient with symptom of neurological claudication were divided into two groups. The patient who could walk less than 30 minutes and patient who could walk more than 30 minutes, and the statistical analysis was done. So this is the analysis for the ODI, this is the analysis for DSCA. The main difference between the back pain and the neurological clotting, but not statistically significant correlation. The DSA and the morphological grading correlation was statistically significant in both less than 30 minutes and more than 30 minutes walking group. The ODI correlation to DSCA, morphological grading, and the sedimentation sign was statistically not significant. The sedimentation sign correlation to morphological grading and the DSCA was statistically not significant. So to conclude, the morphological grading could be a better radiological indicator for assessing the severity of the lumbar canal stenosis than sedimentation sign. We cannot reliably assess the severity of the clinical symptoms using the radiological parameters only. Maybe ODI is not a very good indicator for clinical severity of the symptoms in lumbar canal stenosis. Thank you.